Hi guys, good morning. Hello. Ah, perfect. Perfect. Yeah, no worries. Take your time. For those I just let into, we're just waiting for Emmy to hopefully get the probe. We'll see if we can get it. That way we can screen share and then I can make sure you guys know how to submit. Nice. See if this will work.
Can you see the screen share?
Not really. It looks like a black screen on my end.
What's on ours too?
Yeah. Because you
Gotta see.
definitely were able to at least screen share, so that's 50% of the problem.
Figure it out, Sam.
And if it doesn't work, it's not the end of the world. We can talk through it, but I always feel like being able to see it makes it so much easier. There we go. It's looking better.
It's just going a little slow.
Okay. That's fine too. I can at least get started and then we can see if it'll hopefully it'll go through your apps. Yeah. Okay. It seems like it is.
Oh,
Just slowly.
It's just doing
it's going
it's
real
doing
slow,
its own
sorry.
thing.
It's okay. Oh,
Yay.
oh gosh, good. A great picture of myself. This will be excellent. Cool. I love it. All right, great. Well, we'll deal with that. Is there I wonder if there's a way to get rid of the screen on the video.
Hold on. Let me see if I can. Oh, okay. It's just gonna load for a second. It should be gone soon.
That's okay. No worries. While we're doing that, I'll at least introduce myself. And then do we want to record this? That was the last thing I wanted to do just before. Perfect. All right. Awesome. Well, hi guys. It's nice to meet you. I'm Sarah Gartner. I don't know if I have ever met you guys before, but I'm so excited to be here and kind of get this off the ground. A little bit about me. So I'm actually one of the ER docs over at Evergreen Health. So I work at Kirkland, Monroe, and Redmond. So I might see some of you all kind of in the Monroe, maybe some Kirkland as well. But before I signed with Evergreen, and I've been there now for a couple of years, I did my residency at the University of Washington, and I also did my fellowship there. And so did a fellowship in ultrasound where I also served as an airlift flight physician and kind of merged those two ideas and worked with airlift to get their ultrasound program off the ground. And then I also worked in rural Alaska as well to get some ultrasound programs for a lot of rural providers in that area also off the ground. And so that got me really excited about looking at pre-hospital ultrasound. And then now I work with the medic groups kind of in the area. So I work with Surfer right now. You guys, hopefully Sky Valley soon. I've worked with Redmond as well, and a little bit of King County Medic 1 back in residency as well. So it's been fun. And then I also work with ACEP, the American College of Emergency Physicians, working on trying to standardize a lot of these protocols because right now there's no curriculum that nationally we're all kind of agreeing as to what pre-hospital ultrasound should look like. And so a lot of us kind of in this field are trying to create this to make it a little bit more standardized and make it easier for all of you to use. So anyways, I'm pretty easy to get a hold of. I will share my email as well as my phone number. Reach out whenever, I work days, nights, holidays, weekends, all of those things. So I might not be the quickest to reply depending on if I'm nights and I'm sleeping, but I will try to get back to you as soon as possible. Email is always the easiest, but if there's something more urgent or if you're on on a run and you want to run something by me, feel free to shoot me a text. If I'm available, I am happy to kind of help you guys out. Um, Today, I know you have all gone through the course through the county, which is perfect, which kind of helps get this show on the road. And so today I just want to make sure we're all on the same page to make sure as you start submitting scans, we're doing it appropriately and we're doing it so in a way that you get signed off in the end and then you're not, missing things on the back end and figuring out why didn't Sarah ever tell me that. And so today is more of just about the logistics of all of that to make sure all of your questions are answered. So first off, I guess just generally about the program, and I know Dr. K has kind of set out really great guidelines and we're going to follow those. So each scan that you submit, so you're going to need 25 scans total, basically, to get signed off. And those have to be competent scans. That means that when I go through each scan, you're saving most of the images there. They make sense and, they're correct in your impression. And so there might be a couple that you might have to go over that, aren't exactly competent scans. But for the most part, I'm pretty lenient on a lot of this stuff. And we'll kind of talk about that a little bit today because I want you to get there. I want you to get your 25 scans. And I don't want you to feel like this is the hardest thing in the world. The first couple will feel hard, and then what'll happen is you'll get better at it. And then you'll have some that you're like, man, this was so easy on one patient. Why is this not so easy again? And so that will happen. And then eventually you will kind of get it so it's easy on most patients, like 95%. To conclude a scan, and I know I sent Emmy to like a cheat sheet basically of what I want for each scan. I'm scared to share the screen share just because we got this already set up. But basically, for each scan, you will need a carotid ultrasound looking for a POCUS pulse. I like an anterior view looking both deep for B lines and then shallower for lung sliding. A lateral view to look for like the curtain sign. And then you want your heart views, which would be a parasternal long and a subxiphoid. And I realize that sometimes you might not get both of those. And so you need at least one of those in order for a competent scan. And I can show you guys the cheat sheet too. Was there a question? Sorry, I know there was a little bit of.
Yeah. So
Yeah.
when we did a focus class with the county, they originally had us doing a lateral lung view, and then they told us to stop practicing that and that they didn't want us doing that anymore.
Okay.
So if there's like a video of good placement on that, that would be really
That's
helpful.
fine.
Because like we don't want you guys doing that.
Yeah, I think that's fine. I think initially we were doing lateral lung views and then we weren't. I personally think doing anterior, and that's how I taught the Redmond medics too, is only anterior. And so when Dr. K and I, just so you know a little bit of the history of it, when Dr. K and I initially talked, I was like, let's just do anterior. And then the county taught lateral. And I was like, okay, well, let's just do lateral and anterior. And it sounds like now we flipped only to anterior. So I think that's fine. We can edit that cheat sheet, just not, to not have that. I think as you guys get better, it is kind of nice to get a lateral view because then you can actually look for a pleural effusion or hemothorax. So that's the pro of the lateral view, is to look for the fluid there. Anterior views will show you like pulmonary edema, which to me is the big question. When you have that shortness of breath patient and you're like, is this a COPD exacerbation? Is it a heart failure exacerbation? Do I need to give them fluids, or norepi or what have you? And the anterior lung views will do that for you. So I think I'm fine with that if we want to do anterior only. But just remember that I want both a deep view. So you want to be at about 8 centimeters or so, and that'll allow you to look for B lines. And then I want another view that is just solely of the lung sliding. And so you'll go really shallow in order to optimize the probe view in order to see that lung sliding. So you'll say both of those. Does that make sense?
Thank you.
Cool.
Yeah, and one more question.
Mhm.
Each one of the 25 scans, do we have to do all these views on every patient? Okay.
Yes. Yes. And so try to do them. And it sounds like a lot. Like I remember first learning this, you're like, oh my God, there's no way. But I would swear you will get good at this and you can get this done within 5 minutes, 10 minutes, even less than that, once you get good at it. The first couple of scans you can do on your buddy, right? So like if you're on shift and you have maybe like a BLS guy or a friend or your partner who's there with you, scan them. And your first couple, five or so, can be on just someone else. But after that, then I do want you to be making sure that you are scanning actual patients because you'll notice there's a huge difference between, scanning your buddy on like the floor of the department versus going into the ambulance and trying to see lung sliding and have the vibrations of the ambulance or things moving around. And there's little things that you'll just kind of have to figure out. And we can talk about like the logistics. So for example, for airlift, I taught them the FAST exam, which was a trauma, for trauma. And the truth is like when you get a patient loaded in back to the back of the rotor, there's no way to access the right side of the chest at all. So for them, they had to do at least their left-sided views and everything before they even got into the rotor, or sorry, their right-sided views before they even got into the rotor, and then maybe save the other views for later. So there's and so that's why it's so key and crucial to do it on those patients. If you have that nice, like, 23-year-old that you're, I don't know, transporting that's very stable, that you have nothing to do, scan them first. Like that's an easy one and say, we're practicing this. Patients love to be scanned. They really, really do. And even if you say it's for training, they will not care. I will say 90% of the time. Good. Any questions about that? The 25 scans and the scans that you need. And I'll edit that cheat sheet that the lateral lung can be optional.
And one more question.
Mhm.
When you press the record button, do you just press it once and then do all the views and then stop recording?
No, so do them as separate videos. That's a great question.
Separate
So
videos,
you'll want to
okay.
do them as separate videos. I kind of mess around with this too afterwards. But I want the video recording only to be 6 seconds. And the reason for that, like you can, I think, do a recording for like, I don't know, 2 minutes or what have you, but it's better to only do 6 seconds. And there's a lot of different reasons for that. The biggest reason is when you guys start using this in cardiac arrest, I want you to limit the time that you are off the chest, right? So if you have an ultrasound that is able to do this for 30 seconds, you're totally going to increase your pulse check, like your pulse check time. And that's not what we want. So by inherently having these as smaller video clips, that will also help. And in order to kind of do that, what I say is like, scan first, don't record, look, say, okay, I got lung sliding. Great. Now I'm going to push that red button, get my video clip exactly where I want it, and then it'll save. And so what's nice about that too is once you're done, scanning, it will save all the images. We can actually go through that just so you guys can see it. So who's in charge of the butterfly probe right now? Anybody have it? Who's sharing the screen?
I
Oh,
have it.
perfect. All right, this will be fun. It'll be like Simon Says, me trying to walk you through this, but I think we can we can sort this out. And so everybody hopefully knows the screen. You all use the ultrasounds in the county class. And so when you plug in, what's great about Butterfly is whenever you go into like a new patient, say you see a new patient, say you're on a run, I just want you to plug it into the screen. I don't want you to save any patient info yet. I want you to just get the images first and then save them later. Okay. So this is kind of the screen that you'll come up with. And as you can see, you can have the presets, the freeze button, and then the record button and the actions kind of at the bottom. The presets are important because you need to use the right exam type for each one. And hopefully they explain that at the county class. And so on that cheat sheet, I also have the specific like exam types that you're going to need and want to use for each of the specifics. That's another reason why you shouldn't save just one video, because then you have to change the preset every time too. So let's pretend that we just scanned. I don't know if you have any gel, if you want to scan your arm or what have you, but you can also just save a video of the blank screen. That's fine too. So go ahead and click the record button. Perfect. And so as you can see, it's recording. It has changed, and now you've stopped. And now the moment that you have stopped, you see how there's now like a 1 in the top right corner? That's how many scans you've saved. Okay, so click it again. You can click the record button again.
Hold on,
Oh,
sorry.
that works
It's
too. No, that's fine.
delayed.
That's totally fine. But yeah, so if you click the record button again, you can stop it. It will switch it to 2. And so that way you can see how many scans that you've saved within this study. The other thing that I think is really important, so see that blue dot that's on the top right? That's what's called your leading edge. Now, for the heart views, can you switch the preset to cardiac on that for me? Now, what I have always taught the medics is always have for the cardiac, have that leading edge on the left side. And I don't know exactly how Dr. Johnson had taught you guys at the county class. I'm happy to teach both ways. Oh, excellent. It's coming up on the left side. Perfect. That's what I want. I am a keep it simple, stupid kind of person. So I like every leading edge usually is on the left. So your blue dot should always be on the left. Okay. The reason I bring this up is that sometimes I want you to just like ingrain that you should just look at the blue dot, because sometimes it will be on the right. So for example, double tap that blue dot. If you just double tap it on the screen, hopefully this works, it should flip it to the other side. I know we're having a screen share issue, but yeah, there you go. And then I want you to flip it back. Perfect. So in case, say, you get on shift, this has come up a couple times where I've noticed that in QA, and I've told the medics, hey, do you mind just like flipping the blue dot? Somehow it got flipped sometimes, when you're there. And so always make sure that it's on the left side. Cool. So once you're ready to submit a scan, you did the right thing. You got to click on the number 2, or like the images basically at the top. And what this brings up is now all of the kind of crap that it looks like you have to submit. But there's actually not that much that I need you to necessarily submit. Like you don't need to go through every single thing. The biggest things is for patient details. So click add there. And under the patient details, the only things that I need you to fill out is under the patient name and patient ID. And again, this is in the cheat sheet. I just kind of kept the very big broad strokes of this. But under this, for the last name, this is going to be your last name, because this is how I'm going to know which medic did this scan. So go ahead and put in your last name. And then under all the other stuff, first name, whatever, I don't need any of that. I just need your last name under patient name. And then if you scroll down to patient ID, I also need the run number, if there is one. If it is a coworker scan, just say coworker. You could put in 1, 2, 3. Yeah, exactly. Perfect. And so that's all I need for that. Uh-huh.
Do you need the full run number, or it's just like the last 4? Okay, or
I think it's the last four, which should be fine. And
Okay.
maybe, I mean, and it's more so for you also you can find them. Can you find them fine, like in your system with just the last four? Yeah. So really, again, I'm a KISS principle kind of person. Just do the last four if that's the easiest. And then in the top right, you see that save button where it says patient and save. So all you need to do is the last name and the patient ID. And then after that, you don't need to put in the exam type. I can do that on the end. I don't care that you put that in at all. What I do need is a worksheet, okay? And this is so important, and you can click add for worksheet while we're getting that set up. Um, but this is so important because this tells me what you thought, right? So if you just submit scans and I look at it and I say, wow, that's a cardiac standstill, like this patient is in cardiac arrest, and you're like, and you give me no context on what you think, then that's not going to help me make you better, right? So it is imperative that for each of these, you actually put in a worksheet. So just go ahead and click the patient worksheet. These should both be the same, I think. I mean, is that right? Perfect. Excellent. I love it. And these should be pretty basic. So the ideas that, like POCUS pulse, the options are yes, there's a pulse, no, there's a pulse. An indeterminate scan means you're looking at it and you don't know. Okay. That's one option. Or you try to get a carotid ultrasound and you're like, I don't see anything that actually looks like a carotid artery, right? For example, that comes up a lot of times with the cardiac views. So someone will get a great parasternal lung access and they'll be like, oh, great. I see organized cardiac motion. I see the squeeze. Life is good. And then you go to a subxiphoid view and it's usually this like pot-bellied man that has a huge belly and you're like trying to get in and you have no view and you're like, I don't even think they have a heart because all I can't see anything except bowel gas. And so in that, you might say, organized cardiac motion for parasternal lung, but you might come down here and say indeterminate. And then you'd come down further and say for the right lung, you're going to look mostly for normal lung, which would be that lung sliding. B lines are those horizontal lines. I think of a capital B. So, the capital B has a straight line down. Then your B lines are vertical lines coming from the pleura. You need at least 3 per view or per image to actually call that pulmonary edema. One little line doesn't excite me for anything, but you might see that. But when this says B lines, this means like, you're at least seeing 3 when you show it. No lung sliding, indeterminate, did not obtain. And you'll notice that there's both right lung views as well as left lung views. As you can see, under lateral, I actually is great. This just says optional. So I think that's if it's not in your purview, especially with these initial 25 scans, don't worry about submitting those. Okay. Um, and you'll see that pleural effusion is now an option on the lateral. You cannot see an effusion 95% of the time from an anterior view. So you'll do that for both left and right. Now, in the real, like to get signed off for competency, I only need one side. So if you have that healthy coworker that you're practicing on, or the patient that you got 5 minutes in the back of the rig until you're at the hospital and you only have time to do one side, that's okay if you want to look. But the truth is to make any kind of clinical judgment about a patient, you have to scan both sides. So I would prefer you to scan both the right and left side of the chest, both superficially to look at lung sliding and deep at about 8 centimeters again to look for signs of B lines and pulmonary edema. Okay. So I would prefer to do both sides, but if you do just one, it is okay. Does that make sense, this worksheet? Any questions? Cool. So once that's done, then you can, just click normal lung. I don't know, it doesn't necessarily matter, but you can click some normal lungs there and then click done. Perfect. And so at the end of this, then you see this notes tab. You don't have to fill out a notes if you don't want to, okay? But a lot of the surfer docs and or surfer medics have had this to be really helpful because say you want me to know, like 76-year-old COPD couldn't get a great subxiphoid, thought I was in the right spot, wasn't, whatever it was, or, bad body habitus, any tips on how to make this better, yada, yada. And so you would just put this in the notes tab, and then that way I would have it. And so I can make my feedback to you a little bit better, if that makes sense. You don't have to write anything now, but that's there for you if you want to save it. Okay. So you can just click cancel. And then once that's done, you're going to click save study. Oh yeah, that's great. Sorry, before, well, yeah, perfect, perfect. I was just gonna say before you save it, you can also see your images there. So you don't need to click into it right now, or you can. If you click, you're like too good. You're my Vanna White. You're just excellent over here. But when you click into it, basically it'll have the images that show up for you so you can review what you're scanning. So you can look back into that and say, okay, I got my heart views, I got the lung views, I got the carotid, excellent, everything's done. And then you can go ahead and save that. So maybe you can get back to that main screen, click the X at the top left. Good. And then so this doesn't actually matter if you sign it versus save it. If you save it, then I just sign it on the back end. So I'm fine doing either. I have Surfer doing it as save as draft. So go ahead and just keep it as save as draft. So click save as draft and then confirm. What that allows me to do is just change the worksheet on the back end. If you sign it, then I can't change the worksheet. You will notice that now it's gone. So now your number at the top is 0 because that all saved as a study and is now off to the ether for me to do it. Make sure that you save those because if you do them all together, then it will all come in as one study instead of multiple different patients, okay? Good. I think those are the big things with the ultrasound and submission. The other thing is just looking at the outbox, which I'd have to kind of mess around with the probe to get there. But sometimes what'll happen is and this came up with airlift a lot because we weren't always connected to Wi-Fi. But if you're not connected to Wi-Fi and then the phone finally does get connected to data or is limited, like for example, it looks like you only have 5G in one bar right now. So there's a chance that those images don't get uploaded to the cloud so I can see them. And so in that case, what you want to do is go to the outbox, which I think if you click the down arrow on that, then you should be able to find it there. We'll see. Potentially go to the little blue circle under your name. That might be where it is. I don't know. I haven't messed around with it in a little bit to figure out where outbox is, but just trying to give you some of these. These are just things that comes up kind of frequently. And so I just want to make sure. Go ahead and click left out of the exit. All right, I might have to mess around with it and see if I can find the outbox for you. But you all are decently IT savvy, hopefully. I know it's balanced, but if you can, then you want to make sure that it's submitted, or at least just if you get to good service, then it will submit. It must have already submitted, which is why it's not in your outbox. Okay, does that make sense mostly from a submission standpoint? No big questions. Perfect. That's why. Okay, perfect. That makes sense. So what I'm going to do is I'm going to take over sharing the screen. And so you can end your share. Thank you so much, Vanna White. Appreciate it. Because I want to show you what this looks like on the back end, okay? This is Surfers, but I'm going to pull yours up. The only reason I just have Surfers up is because they have some scans that we can kind of take a look at or go through. And so as you can see, when these scans save, then what this looks like on my end is their last name and the run number, okay? And so that's why it's important for you to at least save that information. Oh, come on. Log back in. So, for examples, we cursed here. So as we go into it, this is what it looks like on my end. These are all the images here that they saved, okay? These are like the heart views that come in that we can look at. And what you can see here on the right is the worksheet. So this is basically what was submitted, so I can go through that and make sure that I diagnosed liver lax within the parenchyma as well as just with an ultrasound here. There's new contrast. You actually in the hospitals, in some hospitals now are giving IV contrast and then doing an ultrasound, which is kind of cool. And you can see liver lax that way. What we can see is free fluid, right? So if the liver lac is big enough, then you can see the bleeding inside the belly. And so that's when we use an ultrasound to look for free fluid. So when I give Zvikor some comments, we'll talk about that and do that in the email. But good. Any questions about that? Does this make sense, though, what it looks like on the back end? Excellent. Awesome, guys. I think those are the big things. Oh, the other thing that I will just show you that everybody will have access to is this is where I keep access to all of your scans. And so this is just an Excel file, basically. And what I'll do is I send it to your email. I will send you guys personalized QA, but I will also save it here. And so, you know, the date, the scanner, whatever, and then the notes. And then we'll have your scan numbers here. And then once you get scanned off, you get a little yellow highlighted, and then I will send a little verification letter to Dr. K as well. But remember, we need 25 total. Cool. All right. I think that's all I have. Any questions about anything? It's a lot of information. I know.
Can you just say one more time what all the required scans are for each
Yeah,
patient?
let me just pull it up. It'll be easier.
Okay. Thanks.
Okay. So this is kind of that cheat sheet guide that you guys will all have, okay? So you need to complete 25 scans, and each scan ideally should have a carotid, cardiac, 2 views of the cardiac, and then lung. Now this says 3 views because this includes the lateral, just to keep it in mind, but you only need necessarily 2 views. I'm going to say here, optional. But so the first one is going to be your carotid ultrasound. And I say this is you're going to use the vascular preset, okay? Vascular carotid preset. And I always just I give like a little blurb of how to do it in a good way. And we'll talk it like as I go through, we can kind of see where your pulsatility is. But for example, the biggest thing with carotid ultrasound that I see is, say you have a tube, right? Basically, it's going through the neck right here and it's vertical. And what happens a lot of the time is people are not right in the middle of the carotid. And so I need you to make sure that the probe is right in the middle. So what you want to do is you want to slide the probe, either medial or lateral, to get it right in the middle, and then push down. If you push directly on the carotid, that's going to help your pulsatility so much. If you are not compressing down exactly on the carotid, it's actually really hard to see pulsatility. And so that's going to be a really important thing that you guys think about. So after the carotid, then I have the cardiac ultrasound here. It's okay if you want to do lung first. I don't care what order you go in. Whatever you do, though, I would just do the same order over and over again, because you're going to get to the point where I like to have a system and I just do it the same every time. But for cardiac, you want to do a subxiphoid view. And then for the parasternal, and then you also want to do a parasternal. And both of those are going to be in the cardiac exam presets. Okay. And then for the lung anterior views, you're going to look for B lines. And I said depth around 10 centimeters, can be around 8 to 10 centimeters. And you're going to assess for B lines. And then you're going to slide up, making the depth really shallow. The shallowest that your butterfly probes go is about 5 centimeters. And so that way you can actually look for lung sliding. Okay. So you're going to do both of those. And then, like I said, optional lateral lung view, and then optional do the other side. But like I said, if you're going to make any clinical judgments on a patient, I would 100% do both scans. Okay. And then just saving scans, kind of just the big things to remember. Does that make sense from the cheat sheet standpoint? Cool. What other questions you guys have? Nothing big? Awesome. I love to hear it. Clear as mud. Excellent. So yeah, so reach out to me how this goes. The first couple are going to be hard. And I realize too, I want the next couple of weeks for you to get the scans. Try to really get this in the next month, because what happens is if you go through the county class and then you wait a month, 2 months, and then you go back and try to do an ultrasound, you're going to be like, I don't remember anything. And this is daunting and scary and I hate it. And I don't want that for you. Okay. And this should be fun. It's going to be hard, but it'll be fun. If you ever need any like specific kind of ultrasound videos or things to look out for, let me know, and I can give you some resources too. Okay. I used to love 5 Minute Sono was my favorite, but I think they now make you pay, which is brand new this year. Very sad. But yeah, I'll find some other resources for you all. Any other questions? Anything burning? Anybody use the ultrasound yet? No. Cool. Mhm. Yeah, because I realize it'll just depend on how many runs you have. And I'm not expecting you to do this on every run. Some of our medics through Surfer love it and they do do it on every run. But I will say at the beginning, you want to get a little bit more confident with it. So definitely use it on the easy patients, the stable patients. And remember that this is not your first priority, right? Airway, breathing, circulation, get IV access, get them on the monitors, right? Figure out what you're going to do first. And then if you have that 5 or 10 minutes afterwards, that's when you use the ultrasound. Once you get good at it, hey, you might want to use that ultrasound sooner rather than later because it's going to change your management, right? But for right now, I want you to kind of use it as like the second, third, fourth priority down the road. I also would prefer you do not use this in cardiac arrest right now until you get better at it, right? Because I want you to be very confident in finding a cardiac view fast, like within seconds, and being able to interpret organized cardiac motion versus cardiac standstill within seconds. And it takes some time. It takes some time. It takes some time to get a good at looking for a carotid pulse too. Not saying, I mean, it's overall easy, but it does take time. And so I just want you guys to be confident before you're making really big decisions for that. Makes sense?
I do have one question.
Mm-hmm.
So when we did the POCUS class for the county, Dr. Ashley said that we could go to the ER to get some scans and like just shadow a doctor. Is that something that you would support as well?
Yeah, I definitely support that. So I think that it depends on your contracts. This is what we've learned. So Sky Valley was trying to figure this out to come to Monroe and scan with me a little bit too on shift. And I think they're still trying to sort out their contract with the hospital in order to make that work. So I don't know for sure. I know that Prov, where Ashley Johnson works, I think those contracts are a little bit more built in. And so feel free if there is a doc that is willing over there to have you scan on shift, I think that that's reasonable. I don't work at Prov and, so it just depends, but I have had medics come in and shadow me for sure, and do the ultrasounds, which is nice because then you have some time. Make sure that you do them on your own butter. Well, the hard part is, well, we can figure it out. But if you do it at the hospital, on person, then you're going to be using the ultrasounds at the hospital, which is not bad. It still gives you technique and practice and things like that. But it's a very different system and I won't be able to see them. So say you end up scanning those. I think what we're going to have to do is you're going to have to take videos of them like on your phone. I don't know. It's going to be kind of tricky and then submit them to me via email or something like that. I don't know. We're going to have to figure that out, which will be a little tricky. I mean, either way, it's going to be hard to get those competence, but I think that scanning real patients like in a hospital setting is nice. So if you want to go in, they might not ideally they would go towards your 25 competent scans, but no, it might be a little tricky for us to see them. So, just keep that in mind. But if you want more practice for sure, it's a good spot to do it. Yeah.
Thank you.
Yeah, you're welcome. Great. Yeah. You might want to talk to Joe. I know Joe Simmons was kind of working through that, so you can talk to him. Cool. Awesome, guys. Well, like I said, reach out. Reach out. I'm happy to. Like I said, email's probably best, but if you need my phone, my phone number is at the bottom of my email too. And so if you need it, it is there for you. I will put it in the chat as well. Good. And then any other questions for me? Oh, awesome, guys. Well, cool. I'm excited. This will be fun. I'm hopeful that you can get the scans. Like I said, try to get these 25 scans hopefully in the next couple months or so. Might be hard with runs and things, but keeping it fresh is going to be the most important. And if you're struggling with that, like you're just struggling getting patients or finding things, please let us know sooner rather than later, because it's harder to like reteach you everything, in 6 months from now. So keep it fresh. Cool. Okay. Yeah, you're welcome. Yeah. Nice to meet you all. Have a good one. Enjoy the sunny day. Bye.